Now, I invite the next speaker, Dr. Ann J.K. She has been the consultant in oculoplasty and neurophthalmology services in Little Flower Hospital, Angamali, for more than 12 years. Over to you, ma'am. She'll be talking on Ectropion.
Thank you, Dr. Indu and KSOS for having me here. So my topic is Ectropion, and few of my slides are overlapping with the previous speakers, so I will skip that. Ectropion, as all of us know, is the outward eversion of the lid margin, and like many other conditions, it is also classified as acquired and congenital. Congenital is not very rare, but acquired is more common, of which involutional or senile ectropion is the most common. Other types are cicatricial, paralytic, mechanical. Involutional ectropion, before that we have to know what is the support of the lower lid. So lower lid is supported by a tarso-ligamentous sling, which is consisting of medial canthal tendon, lateral canthal tendon, tarsal plate, and also capsular palpebral fascia and orbicularis. So the laxity of this tarso-ligamentous sling can give rise to horizontal lengthening of the lid, horizontal lid lengthening, and generalized loss of elastin can cause thinning of the tarsal plate, along with orbicularis atrophy can contribute to involutional ectropion. So evaluation, horizontal laxity, to measure horizontal laxity, you just have to pull the lid away from the globe, and the displacement, if it is more than 2 millimeter, that means there is horizontal laxity. For medial canthal tendon laxity, pull the lid laterally and note the displacement of the punctum. If it is more than 2 millimeter, up to 2 millimeter is normal. If it is more than 2 millimeter, it is mild, and moderate if it is up to the limbus, and if it is severe, it will reach up to the pupil. And look for the signs of facial nerve palsy also, like lag of thalamus, absent wrinkles over the forehead, deviation of angle of mouth. Also make a note of condition of the puncta, that is whether it is stenosed, everted, and also keratinization of lid margins is there, any misdirected lashes, and the condition of ocular surface. And about the lateral canthal tendon laxity, lateral canthal angle has an acute configuration. So when it is rounded like this, that means there is disinsertion or laxity of the lateral canthal tendon. And if you pull the lateral canthal tendon medially more than 2 millimeter, that means there is laxity. So there is a grading system. Normally, in normal lower lid, you should not see the punctum unless you pull it down. And in grade 1, you can see only the punctum is everted, grade 1 ectropion. If the palpebral conjunctiva is seen, it is grade 2. And if the fornix is also visible, that is grade 3. So coming to the management of generalized ectropion, if there is horizontal lid shortening, you can do a pentagon excision. And size of the pentagon will depend upon the amount of laxity, and you can suture it just like you do a lid tear suturing. So where you put the pentagon is like where is the most dependent part of the ectropion. And the details of suturing Dr. Indu will be dealing with. Medial ectropion, here, if it is only medial ectropion, you can excise a tarso-conjunctival diamond from the conjunctiva, that is from inferior part of the punctum, and put it in such a way, everting sutures are put so that it is inverted. If it is associated with horizontal lid laxity also, you have to combine with pentagon excision. So most of the times these procedures are not done in isolation. You have to combine it with other procedures also. This is a procedure done in minimal punctal ectropion, that is you can cauterize the conjunctiva and tarsal plate beneath the punctum, taking care not to injure the canaliculus. So this will give inversion of the punctum. Then comes lateral tarsal strip. So my previous speakers has already described it in detail. So what we do is, this is to tighten the lateral canthal tendon and also to correct the horizontal lid laxity. So a lateral canthotomy is done, inferior cantholysis is done, and a tarsal strip is fashioned and it is attached to the periorbital, lateral orbital rim. And this is the video. I am not showing it since Dr. Shruti has given a detailed description. And the points to be noted is like it has to be at a higher level and it is should be at the from the inner aspect of the lid. And then only the tears will flow to the punctum and it will not stand out like. And the tension you have to assess by, it should be under adequate tension, otherwise it will cause entropion or ectropion. So this procedure can be done both in entropion and ectropion. Then comes cicatricial ectropion. So cicatricial ectropion is seen in upper lid also in some congenital conditions like ichthyosis. So I am talking about acquired ectropion, mostly traumatic. This is due to shortening of the anterior lamella, that is skin and orbicularis. It can be either localized or generalized. In localized ectropion, this lady has got a trauma and after healing this led to a contracture of the skin and anterior lamella here. And this is a generalized ectropion caused by facial burns. Management, it can be either medical or surgical or combination of both. So you can do scar massage in the immediate post-op period. That is after the wound has healed. When the skin has healed after 2 weeks, suture removal, the scar massage will help by disruption of the fibrinocytes and also collagen disruption. So what you do is, if it is a vertical scar, you have to massage in the upward direction. And it can also be combined with intralesional injection of immunomodulators, steroids, triamcinolone 40 mg per ml concentration, you can do it. And multiple sessions you can give 2 to 3 weeks apart. Along with that, scar massage is also done. Or 5-fluorouracil is another immunomodulator. So this patient had a bad lid tear, and after that, this is the picture after 1 or 2 months. So he has got a scar and contracture there, and he has an ectropion here. So we did a scar release, and multiple injections were given along with the scar massage. And after 3 months, there is improvement in the quality of the scar. This lady I have shown previously, cicatricial ectropion, because she had sufficient horizontal lid laxity. We did a scar release and excision of the scar with pentagon excision. And after surgery, there is some dent here, but the scar is much better. And this we can manage with massage and medical management, intralesional injections. Surgical management includes plasty, flaps, etc. So this is a Z plasty. So here the vertical scar is turned into a Z, so that flaps are taken so that the vertical thing is, the flaps are reoriented in such a way that this vertical segment is lengthened, which improved his ectropion. If there is a considerable amount of contraction, we have to go for flaps or grafts. Either full thickness or partial thickness grafts has to be taken. So the problem is you have to find a matching skin. The eyelid skin is very peculiar in its thinness, and it has no subcutaneous fat. So the most matching lid skin would be upper eyelid skin. Other options are retroauricular skin, supraclavicular skin, and upper inner arm skin. So this girl came with a history of abscess here, and it ruptured, and finally she had ectropion here, and her complaint was watering. So a skin graft was it was taken from the upper lid, and this is after 2 weeks, and after 2 months, this is the appearance. Some pigmentation is there, but the ectropion is relieved. paralytic ectropion, patient will come with lag of thalamus and watering. So Dr. Shruti has had a talk extensively about it. So look for the signs of facial nerve palsy. And watering is due to decreased orbicularis tone, corneal exposure, etc. So even if you correct the ectropion, patient may not be relieved of watering. So you have to warn the patient about that. And in mild cases, you can do lateral canthal sling and tarsography also. And if required, you have to do medial canthoplasty also. Finally, mechanical ectropion. So this is caused by the mass near the lid margin. So the treatment is removal of the causative agent, that is the mass, and you have to reconstruct the lid by appropriate methods depending upon the pathology.